Let's talk about MAID, because this is probably the topic I get more questions on than anything else I do. So, for a little background on me, I've worked in home care for most of my nursing career and have specialized in palliative care. To me, MAID is sort of one of the options for end of life care, but I know some people keep those very separate, which is why I point that out. I've been assisting with medically assisted deaths for over 6 years now. Last month, I attended somewhere around 25. So I've gained a lot of experience in this. I've probably attended more provisions than any other nurse. So I get a lot of questions and thought I would cover some of them in a video here. Today, I want to talk about what the nurse's role is in a medically assisted death in the home. And when I say home, I don't necessarily mean their actual home. It's their environment. It might be their home. It may be a friend or loved one's home, hotel, retirement home, long-term care, or the funeral home, which is the environment that tends to rattle people the most to hear. For the nurse's role, the big focus is actually on starting the IV. There's a supporting role in being able to communicate and stuff that are important as well, but if we can't start that IV, the provision doesn't happen. So it's high pressure, and you're starting an IV on someone who's typically a difficult IV start. These are people who've been very sick, had a lot of different treatments, often peripheral chemo, things like that. So it's high pressure and it's difficult. And that's what takes the most skill in this, outside of being able to walk in and meet somebody for the first time to help them die. When I get there, I'm going to walk in, obviously introduce myself. Hi, I'm Alicia, I'm the nurse. If I'm arriving with the nurse practitioner or doctor, I will then pause and let them say what they're going to say, which is typically obtaining final consent, at which point I'll ask if it's okay to start the IV now. I'm going to look at the veins and see where I can get the best IV. I have standing orders with all the doctors and nurse practitioner to obtain access anywhere I can get it. So I'll look at hands, arms, feet. Once somebody mentioned the neck, I haven't had to do that. It's kind of a possibility, I guess. But the point is, you have to get an IV, because the alternative is that they would have to wait until we can coordinate getting a central line or seeing if someone's available to come start an IO, which is really, really uncomfortable. Not to mention, I can't imagine mentally processing that I've scheduled my death and then being like, maybe not. It's a very emotional decision to process, and I can't imagine a major delays and being responsible for that. I know that that's a stressor for other people as well, so that's why I point that out. I'm going to go for the biggest gauge I can get though, which is typically in the kits a 20 gauge. I'll look for a vein that I can try to put that in before I'll go with a different IV site that maybe won't hold as big of a gauge. This is because we're giving high volumes of medications through various sized syringes, and the velocity then changes based on the IV gauge. If you're pushing that fluid through a really narrow gauge, the veins tend to blow when they're very fragile. Typical process would be to start 2 IVs. Because I have done this a lot for a long time with the whole team, they'll typically go ahead with just one if I'm confident that that's one good IV, or if I'm like, this is all you're getting, then they're going to go ahead and they're going to be very careful. And if I can only start at 22 or 24, I haven't started at 24 in a few years, but if I'm starting at 24, we're going to really baby that IV, because that's all there is. Once the IV is in, I'm going to step back out, go see the doctor or nurse practitioner, let them know what I've started and where, and then assist if there's any more meds to be drawn up, etc. When that's ready and the family and patient are ready, we're going to go back in, and at that point, my role is timekeeping. So recording when the meds are given and when the pronouncement is done. During that time, if there's like oxygen running or anything like that, I'm going to step out and go shut that off, because it makes a lot of noise, and also so that we can demedicalize to an extent. Once the pronouncement's done and I've recorded that, typically we step back out, give the family some time before I go back in and do aftercare, which is primarily removing that IV, but if there's sub-Q sites or catheter or anything like that to remove that I'm aware of, then I will do that as well. After that, it's mostly like follow-up, so with the funeral home, any meds that need to be discarded, that sort of thing, followed by offering well wishes, condolences, etc. Maybe some story time. It's always great to hear stories of people talking about their loved ones from years past and that sort of thing, travel, things like that. Great to hear stories and get to know people in these moments. Once everything's done though, we offer condolences, well wishes, and we're on our way. So if you have any questions, you can feel free to drop them below. I'd be happy to answer, or you can send me a message. But that's sort of the nursing role of assisting someone with a medically assisted death in the home.